All right, to start off this morning, I want to apologize, but we're going to focus on one of our patients who's got kind of an acute problem. That's something bothering her since her surgery, and that is pain in the neck.
Yes, other than you.
Good thing you got that out first, because I was coming with it second, so that was good. You're right.
After last week, you owe that to me. I deserved it. Yeah.
I was going to say, she's been a pain in the neck since she got it. So let's go. You had surgery, and the surgery, as I recall, the surgery itself went well.
Right.
And then you and I have been in communication via iPhone.
Right.
You've been emailing back and forth. You have some underlying medical problems. You have some version of heart failure.
Right.
Maybe not classical heart failure, but kind of a diastolic right side of something.
Right.
And you're on some what called afterload reduction.
Right.
With the Atacand. You're also on a fluid pill, Lasix, and then you have the neck disease that you knew about.
Yeah, just it's being an old fart, degenerative disc disease.
So you have DJD,
right.
degenerative joint disease in the cervical spine that you've known about.
Right.
And after surgery in clinic, the morning after, as I recall, you were having some kind of the burping, some abdominal pains
right.
and things like that, which we kind of put off as being somewhat expected.
Right.
But over the past 2 or 3 days, the really big issue right now is the severity of your neck pain.
Yeah, from my neck down, I feel terrific.
I'm not touching it. I'm just skipping
Smart
that.
move.
Okay, I'm just gonna let that one go. I saw the fastball and I said, I'm gonna let that one go. But now, the neck pain that you have, similar to neck pain you've had in the past? I mean, this is an acute exacerbation, somewhat different?
It's totally different.
And it's bilateral? Or
yes, it's bilateral, it's restriction. I can't turn either direction very far.
okay.
I never had that.
So what I would say, not knowing, that not being my field, I mean, I'm an ultra specialist in general surgery, let alone general medicine. What I would ask is it appropriate, you know, with your medical background, to have you seen today in the ER, to have x-rays, and have somebody who knows about neurologic or orthopedic or other things better than I do, see you prior to you making any further decisions? Or you think it's more mild and that's not necessary?
Well, it's not more mild, I just don't know what the ER, that's what I do, could do for me, but I'm at the point where they might be able to give me something, muscle relaxant, or check to see if the facets are locked. I don't know.
Well, I guess that would be my question. You know, with your background as a physician, I'm a little bit loath to just tell you what to do. But, I mean, what I would tell you what to do is go see a doctor, you know, who knows more about that. And if they feel uncomfortable with their knowledge base, you know, they would ramp it up. And they might be able, as you point out, to get some kind of radiologic study and things like that. So, in the nicest possible way, I'd like to say I'm not certain what, you know, the neck issue is. You know, just looking at you and your motion, I mean, it doesn't sound like you have, you know, loss of function in a nerve root anywhere or anything like that. You just got pain. Is that
Right.
correct?
Yeah, it did radiate both shoulders, but I had a massage and I got better motion. I just had my shoulders massaged.
Right. And then we had one other thing I think you and I talked about, and that is that you have tried the single dose of 800 milligrams of Motrin.
Yes, sir. Right.
And what happened with that? You want to tell us?
Well, I've been taking the Tylenol, and it decreases the pain for 3.5 hours, and I can move a little bit further. And then when you recommended that, I tried that, and it did almost the same as the Tylenol. So I have relief from both of those, but I like Motrin better because it's an anti-inflammatory.
Right. Well, that was one of the things. Maybe I can help with that. You're being blocked from your own idea of taking, say, Motrin or something like that, because of my recommendation that we avoid that because of its risk to the lining of the stomach, gastritis, and things like that. And that is our general rule because we fear gastritis, ulcers, bleeding ulcers, perforated ulcers, and things like that. On the other hand, we have had a lot of experience where patients in the postoperative period suffer from a somewhat similar situation, and that is they get an acute gout attack. and I think we talked a little bit about that last week, that we often see a pretty significant flare of gout. And in getting advice from our consultants, we've often seen them select indomethacin, colchicine, ibuprofen, Motrin, or steroids, all of which are highly ulcerogenic, as you well know. But when you have that gout attack, in chatting with the referring physicians, the specialists who consulted on my patients, what they say is, that's all we got. Those are the things, and they're the things that we used back in the 1800s when I went to medical school. They haven't really changed much, and so I keep sending people back hoping I'll learn more, and I don't think they've changed much. The interesting thing, the potentially valuable thing for you in your situation is, I think that if I hear you right, if you get pretty good relief from that Motrin, then it might be that a couple of days, a couple of doses of that might be reasonable while you get a more extensive evaluation.
Yeah, that would at least allow me to get home and, see an orthopod there or something.
Okay. You'd prefer that over here?
Well, I don't know, but you may have more efficient medical service than the Navy does.
Well, I think we're probably neck and neck, Not to say anything, but the Catholics and the Navy, they're right together on efficiency, I think.
So I'll see about going into clinic.
Okay. Is there anything else that you and I can talk about as far as that I can help with? I think the one thing I might be able to give you information on is that we have had people on high dose colchicine, indomethacin, or steroid dose packs in the postoperative period. Although we don't like that, we've seen people do quite well with it. Certainly if you're going to be doing that, then all the other kind of prophylactic measures get magnified in their importance. So taking the yogurt, taking the Tums, taking the Prilosec, or in your case, the Acifex, I think get magnified in their importance of trying to protect that gastric lining. Well, if you do end up taking, say, a couple of days of the Motrin and drugs like that. I'm not sure I was very good on giving an answer on that, but I think that's the best I can come up with. If that's.
Yes, sir.
Are there other things that we should talk about on that, or?
On that, no.
And again, just to press you a little bit, you don't think that, given your assessment, that you need to be in the ER today to examine?
I don't know. We'll see at the end of clinic.
Okay. So if I give you a very difficult clinic, I might be able to force you into the ER. Is that right? Okay. I see
the staples out of my
I
head.
see. I see my